Okay, I think we should get ready and get started. I want to welcome everybody to today's webinar um, uh, entitled Intermediate Level Webinar, Building on Your Experience in Evidence-Based Hearing Screening Practices for Children Birth to 5 years of age. I'm Will Iserman, and I am the director of the Early Childhood Hearing Outreach Initiative known as the ECHO Initiative at Utah State University. The ECHO initiative is housed within the National Center for Hearing Assessment and Management at Utah State University, of which I'm the associate director. NCHAM serves as the Early Hearing Detection and Intervention National Technical Resource Center, funded by through a cooperative agreement with the Maternal and Child Health Bureau. Since 2001, for about 20 years, the ECHO initiative served as a national resource center on early hearing detection with a focus specifically on supporting Head Start and early Head Start programs in implementing evidence-based hearing screening and follow-up practices. And we're delighted to be able to continue to make our resources and other learning opportunities available to staff from Head Start programs as well as to anyone from early care and education environments who can put these to use. Um, Now, before we go any further, I want to just give a quick shout out to our captioners, our captioner and our interpreters today. A big thank you for them offering their services in helping us make this webinar accessible today. So thank you to those of you who are offering that service. Now, I'm joined today by Dr. Terry Faust, who is a longtime colleague and friend and who is a pediatric audiologist and a speech language pathologist who has served as a consultant and trainer with the ECHO initiative since our very beginning.
Thank you, William, and good afternoon, everyone. I so appreciate our time with you. Yes, as William has said, William and I, along with many other ECHO team staff, as well as local collaborators, we've provided training in nearly every state with thousands of staff from early Head Start, American Indian, Alaska Native Head Start, and Migrant Head Start programs, as well as many other early care and education programs over the years. And we are always encouraged, just as we are today, by the huge amount of interest that there is in establishing evidence-based hearing screening programs so that children with hearing-related needs can be identified and served.
Okay, I'm going to turn off my video so you can look at the more attractive things that we have prepared for you to look at today and our interpreter. So I'm going to turn off my video and then we will proceed. Thanks, Terry. So just so that you know, today's webinar is being recorded. So if anything disrupts your full participation in today's webinar, you'll be able to stream it again on infanthearing.org or kidshearing.org in the next couple of days. So, and keep that in mind also, if there is anybody that you think would benefit from today's webinar that isn't attending live. So be aware of that. Terry, I don't know if you're aware that your video is on in case you didn't intend to do that. Just thought I'd let you know. So today's webinar is primarily intended for those of you who already have some experience implementing evidence-based hearing screening for children, either in the birth to 3 range or in the 3 to 5 age range, or both. We're delighted to have well over 800 people registered for today's webinar, and many of you submitted questions to us in advance, and our responses to those questions we tried to incorporate into what we've planned to share with you today. We should have ample time to take additional questions if others come up during the presentation. We did notice that there are a few questions that have popped up from folks for whom evidence-based screening is new. And if that's you, by all means, you're welcome to stay throughout today's webinar and hear what other people who have been doing this for a while are asking about and learning about But know that we wanted to let you know that tomorrow we're having an introductory webinar for those of you for whom OAE and other evidence-based screening is a new topic. So if you go to kidshearing.org, you'll find the link to that webinar if that suits your needs more appropriately. But again, you're welcome to stay with us. Now we're going to organize our time today around a lot of the questions, as I said, that you have sent to us. And we'll present some information about each of these topics. We'll start with a brief review for our newcomers to evidence-based hearing screening on the purpose of hearing screening and what the recommended methods are. We're then going to turn our attention to review the issues pertaining to Pure Tone Audiometry method and to some of the questions that we've gotten about screening children 3 to 5 years of age using that method. Since many of you are getting ready for a new round of screenings, we'll go over some key steps you'll want to complete to prepare for this. We'll then review the steps and the procedures of the Pure Tone screening just to make sure that you have those covered as well. After we do that, then we'll switch our attention over to otoacoustic emissions screening, which many of you are doing. And since some of you are also preparing for a new round of screening with a group of children using OAEs, we'll overview the steps you'll want to complete to prepare for doing OAE screenings. We'll then review that procedure, some helpful hints for screening, and then delve into some of your questions about children who may be challenging to screen or other issues you brought to our attention. We'll then, that'll then be an opportunity for you to ask us some questions about OAE screening. Next, we're going to talk about the follow-up protocol, which relates to everyone, regardless of which method you're using. We'll talk to some of the issues about follow-up and communication with parents and healthcare providers and how to appropriately support the follow-up actions that need to happen. And then we'll wrap up by taking a look at some of our additional resources that we have available and making sure that you know what else is available on our website. We're going to organize our time around this left bar that you see on the left so you can follow along which topic we're on. And this is helpful to look at too if you're looking at this in the recorded format. If you want to advance forward, you can see where in today's discussion we are by looking at that left menu bar. So you've probably seen this graphic before. We use it a lot to remind people that the work of the ECHO initiative is based on the recognition that each day there are young children who are deaf or hard of hearing being served in early childhood education and healthcare settings, often without their hearing-related needs being known. Hearing loss is often thought of as the invisible condition. So the question for all of us is, how can we reliably identify which children have normal hearing and which may not?
And the short answer to that, William, and to everybody is that early care and education providers can be trained to conduct evidence-based hearing screening, just like you see here in these photos. And the ultimate outcome of a hearing screening program is that we can identify children who are deaf or hard of hearing who have not been identified previously. So you should recognize or will recognize the procedure on the left as otoacoustic emissions or OAE screening, which is the recommended method for children birth to 3 years of age and is increasingly recommended for children 3 to 5 years of age as well. Now on the right, you'll see the procedure Pure Tone Audiometry hearing screening, which has historically been the most commonly used screening method for children 3 years of age of older, which you'll still see in many early care many early care and education providers using. Now, as William mentioned, we'll be talking about both of these methods today, keeping in mind that the hearing screening process does not diagnose a hearing loss, but it does identify children who need further follow-up evaluation, either by a healthcare provider or an audiologist, with that ultimate aim of diagnosing a hearing loss if in fact that exists, and then connecting those children with the intervention services that they need. So your screening program is the first important step in that process.
Now, some of you have asked whether you need to be certified to do screenings, and that tends to be a state-specific issue. We don't know of any states that actually require that, but there are some state guidelines that can influence your practices. So we always encourage you to check that out. A good way to do that is by connecting with your state newborn hearing screening office, or what's called the Early Hearing Detection and Intervention Coordinator, known by the acronym EHDI or EDI. And we have a link to those offices on our website, which I'll be showing you a bit in a bit. If you look for Find an Audiologist on our website, that's how you'll find the EDI coordinator for your specific state to whom you can address questions like that. Now, some of you have also asked about how we can more effectively encourage parents to follow up when a child hasn't passed a screening. Now, one way to do that is to share information about the incidence of hearing loss and the fact that a child's hearing ability can change at any time, often without us even recognizing that. And so let's just review some of these really helpful basic facts. About 3 children in every 1,000 are born with a hearing loss, deaf or hard of hearing. Now, most newborns in the U.S. are now screened for hearing loss using evidence-based methods, most of them before even leaving the hospital. But screening at the newborn period isn't enough, because the research suggests that the incidence of permanent hearing loss actually doubles between birth and school age, from about 3 children in 1,000 at birth to about 6 in 1,000 by the time children enter school. So that's a really good fact for you to have in your mind, ready to share with parents to reinforce the value of following up.
So we can't only screen then for hearing loss at birth. So we actually need to screen throughout early childhood, because hearing loss can occur anytime as a result of illness, physical trauma, or environmental or genetic factors. This is often referred to as late onset hearing loss, just meaning that it's acquired after the newborn period. And again, similar to subtle changes in vision that it can occur for any of us, a child can experience a change in hearing ability that we want to identify, so they have full access to language and then all of the information that they can be exposed to as they learn and grow. So screening is just that first step in the process of identifying a disability such as hearing loss. Now, since no screening method is 100% effective in identifying possible areas of concern, parent or caregiver concerns always overrides a passing screening result, no matter what the screening method is that was used.
Yeah, any conversation we have about screening and follow-up should always begin with a reminder that screening methods aren't perfect, and that whenever a parent or caregiver expresses a concern about language or hearing, children should be referred for a more thorough evaluation, even if the child passed the hearing screening. And that's true even with the highly reliable hearing screening methods we're talking about today.
And we also want to acknowledge right up front that for any number of reasons, there will be an occasional child that you just can't manage to screen. So after you've tried everything you can do, and you've had a colleague try as well as possible, you'll be faced then with the dilemma of what to do. So here's our recommendation about that question, which some of you have raised. If you aren't successful screening a child, then refer the child to someone who can. Often that's going to be a pediatric audiologist. Just keep in mind, sometimes the children that you may have difficulty screening are actually the very ones who have a hearing loss. So we don't want to skip them and just try next year.
So we just mentioned having a pediatric audiologist in the picture. A pediatric audiologist, if you don't know, is a professional who specializes in the diagnosis and non-medical treatment of hearing-related and other disorders associated with the ear and the auditory system. Terry's a pediatric audiologist and he specializes in children. So having access to a local pediatric audiologist can really be helpful. We recommend that all programs consult with a local audiologist if at all possible to help develop and oversee your hearing screening and follow-up activities. They can be helpful with equipment questions you might have, consult with you about specific children who aren't passing your screenings, and importantly, they can be a valuable resource when you need to refer a child for further evaluation. Now, on our website at kidshearing.org, you'll find a link for Find an Audiologist, which should help you do just that. And there are several different directories there. And as I mentioned before, going to your EDI coordinator for your state, the newborn hearing screening director, they can help you find local audiologists.
Now, I just want to also mention here to all of us that some of you have submitted some very specific questions about error messages that occur on your particular piece of equipment. And while I can so appreciate those questions, it'll be difficult for it to address specific equipment messages and things like that in a group setting remotely like this. But you could pose those questions to the person who sold you the equipment. While equipment distributors and salespeople are not who you should look for the comprehensive training you need to develop your screening program, they can absolutely help you understand how your equipment functions, the error messages, and things like that. So having access, as William said, to a pediatric audiologist and your sales rep will really be helpful, but for different reasons. So we encourage you to have their contact information ready for when you need it. And then sometimes the equipment manual, which is now often online or mostly online, can help you as well.
Hey, Terry, while we're on that topic, some people submitted questions about screening children with PE tubes. So let's just answer that question right now.
Oh, yes. Yeah, let's. So yes, you absolutely can and should screen children who you know have PE tubes. It's one way to actually find out if the tubes are doing the job they've put in to do. Children with PE tubes should pass hearing screenings if the rest of their auditory system is functioning normally. So for those of you that are using the OAE method, you'll want to look at your equipment manual just to make sure. In some cases, you might have to push an extra button or to adjust the setting for screening an ear that has PE tubes. So be sure to check that out. As I said, some equipment does require a temporary adjustment while other brands do not. But the bottom line is, yes, you can and should screen children with PE tubes.
Okay, so we have two screening methods we want to talk about today. By way of big picture, if you're responsible for children who are under 3 years of age, the recommended method is OAE screening, which you see here on the left. If you're responsible for screening children 3 years of age or older, historically, Pure Tone Audiometry has been considered the recommended method for this age group. This is the headset screening where the child raises a hand or performs another task each time they hear a sound that's presented into one of the earphones. You see this method here on the right.
Now, several of you have asked why some programs, you may have noticed, some programs are no longer using Pure Tone Audiometry with the 3 to 5 population and have switched to OAEs. And that's because there's growing recognition that although the Pure Tone method has been the most widely used method historically, it may not always be the most feasible method to use with some of these younger children. The research shows that 20 to 25% of children in that 3 to 5 age group can't be screened successfully with this methodology, just because they aren't developmentally able to follow the directions reliably. And that's really been our experience as well. So in those instances, OAE screening is the preferred method for these children. And as we emphasized a moment ago, we want to screen every child, even the ones we find challenging to screen, right?
So at a minimum, if you're establishing evidence-based hearing screening practices for 3 to 5-year-olds, and if you're considering or are using pure tone screening, you'll also need to be prepared and equipped to do OAEs on that 20 or 25% who can't be screened with pure tones. Or alternatively, you need to have some other means for systematically referring all of those children that you can't screen with pure tones to an audiologist who can perform the screening, which frankly can be a bit challenging in its own right. If you've got 20% of the children you see that need to be referred to an audiologist, that could be kind of tough because audiologists don't have that much time to see that many children.
To simplify things, then more and more audiologists are recommending the use of OAEs just uniformly with all children 3 years of age and older. And it's because it's quicker than pure tone screening, both to learn to do and to actually implement. But really, it's far more likely to be a method that can work across the board with all children in the 3 to 5 age group you'd be screening, and it's equally as effective.
So if you or your program are undecided or you're reevaluating this question now that you're at the beginning of a new school year, about which method to use primarily for children 3 years of age and older, we want to encourage you to carefully review a document we have on our website that compares OAE screening and pure tone screening with this 3 to 5-year-old population. It's a document that really helps you walk through the considerations of that decision. Now, here's an important note. Some states do have regulations about what methods are to be used based on age, requiring pure tone for children 3 years and older as at least the primary method. So you need to check with your state if you're considering OAEs for the 3 to 5 age group. And you can do that, again, by contacting your state's newborn hearing screening program. They'll be able to help you find those rules or regulations if they don't know them right off the top of their head, which they very well may. You'll find that link on our website, which I mentioned. Now, on another note, we had a question about whether there are any other recommended evidence-based practices other than OAEs or pure tone audiometry. Are there other methods, Terry? What's your answer to that question?
Yeah, they're not. These are the two methods that have been studied, validated, and in use.
All right. So Terry, I'm going to hand it over to you to jump into pure tone audiometry.
Great, thank you so much. So let's jump right into our first screening method and review it. So to conduct pure tone screening, we're going to first take a look at the ear. We want to make sure that there's no visible sign of infection or blockage. Now, by the way, you'll always want to do this first, regardless of what method you're using. So if the ear appears normal, then you as the screener are going to instruct or condition the child how to listen for a tone and then respond by raising a hand or placing a toy in a bucket. And once you've observed that the child reliably responds to the sounds that are presented, just as you instructed, that's when the actual screening is started. During the screening process, this listen and respond game is repeated at least twice at 3 different pitches on each ear, noting the child's response or lack of response after each tone is presented. If the child responds appropriately and consistently to the range of tones presented to each ear, then the child passes the screening. Now, again, as I mentioned, during the screening process, this listen and respond game is repeated at least twice at 3 different pitches on each ear, noting the child's response or lack of response after each tone is presented. Now, if the child responds appropriately and consistently to that range of tones presented to each ear, the child passes the screening.
We want to remind you of some things you'll want to be sure to address as you get ready to start screening a group of children. Now, to begin with, and this goes for everybody, regardless of what method you're using, be sure to refresh yourself on the resources that we've got at kidshearing.org. This is our landing page of kidshearing.org, where you'll find a range of resources there if you're needing to acquaint new staff or to refresh yourself. So we'll just have a look here at the various resources we've got here, starting with big picture resources, where to find the training that is available online, both for OAE and for Pure Tone Audiometry. Those trainings are great to do on an annual basis, provide you with a certificate of completion, and is a great standardized way of making sure that everybody is reviewing exactly the same processes for each of these methods. You'll find our screening resources in the next group, where you'll find a guide, a checklist for preparing to screen, our protocol guides and forms for documenting screening outcomes, information on sharing results, including referral letters in English and in Spanish, letters you can send to healthcare providers or audiologists with screening results, and even some recommended scripts about what to say when a child does or doesn't pass to parents. You'll also find some follow-up resources there. I also want to note, if there are some of you who are actually using the online training up above, there are some new modules in there that review the documentation process and tracking process for a group of children. So you might want to go and have a look at those if you're already registered for those courses. As you prepare for a round of screening, you'll want to walk through these steps to make sure you've addressed each of these. And you'll see here that there are things about setting up the environment, doing a listening check on the equipment, just a variety of things to walk through as you get ready to screen. So be sure to look at that. And again, that's available on our website as well. So you don't have to memorize any of that stuff. Now, let's just walk through the process of screening that you reviewed, Terry, as a refresher, and we'll address a few questions some of you submitted to us. This is the screening form that we provide for you to use for Pure Tone screening, which actually follows the recommended protocol exactly, step by step, and gives you an easy way to document each of the steps as you go. The first step for hearing screening is to conduct a visual inspection of the outer ear. Now, in most cases, the child will pass at this point, and you'll move on to condition the child for the screening process, which Terry mentioned. If the child cannot be successfully conditioned to provide that behavioral response to the presentation of sounds in the earphone, another attempt to condition the child can be made on another day. If the child still cannot be conditioned, then an OAE screening should be conducted, or the child should be referred to an audiologist. Assuming the child is conditioned successfully, then the screening process begins.
Let me just interject here, William. We have received some questions about the conditioning process in preparation for today's webinar, asking about how long the conditioning process should take. So let me go ahead and answer that. Children who are going to who are going to be successfully screened using the Pure Tone method, they ought to be able to be screened in about 10 to 15 minutes maximum, including that conditioning step. So the conditioning should not take more than 5 minutes, hopefully less. If you can't condition a child in that amount of time, then you probably should consider using your backup plan, which is either to do the OAE, hopefully right there, right then, while you have the child there, or you can try on another day if you have the flexibility to do that. But just remember, if you can't screen the child, you'll either need to do an OAE or refer the child to someone who will be able to successfully screen the child, most likely a pediatric audiologist. And as we said earlier, remember that some children who have hearing loss could just be the very ones who are most difficult to condition to do the screening. So one way or another, we want to ensure that every child gets screened.
Assuming the child is successfully conditioned, the screening process begins. Now, you can note that the form provides space to record the results of each ear. Now, since Pure Tone screening isn't automated, the form provides a reminder that for each ear, up to 4 presentations of the tone can be made for each frequency level, starting at 2,000, then 4,000, then 1,000, and that 2 responses are needed for the child to pass for a given tone. The screening begins by repeating the conditioning process one more time, and then proceeding. From there, documenting the results for each presentation as you go. Once you've completed the presentations across all 3 frequency levels, the form reminds you how to determine if the child passes for that ear. The child needs to have at least 2 successful responses out of no more than 4 attempts at each frequency level in order to have an overall pass. Now, once that's recorded, then you screen the left ear. And you do that in the same way, recording each presentation as you go. Now, if one or more ears doesn't pass, doesn't meet that criteria, like you see here on the right, then a second screening is going to be done approximately 2 weeks later. And the form reminds you to do that.
William, let me interject with another question someone has raised in a previous communication to us. The question is, what if a child does fine in responding at first, but then becomes distracted, or you observe they're no longer engaged in the screening, say after the first couple of pitches? What do you do? And this can absolutely happen. So if it does, be sure to document as far as you got, and then you can do one of several things. You could use your backup method, the OAE instead, or you can come back to this child on another day and continue where you left off, making sure, however, that you always start by repeating that conditioning process before you continue with the actual screening steps where you left off.
Harry, you'd have to do the same thing, right? If there is a sudden increase in the environmental noise that's outside of your control too, right, Terry? If you can't continue to screen at that time, you'd have to come back at another time, picking up where you left off.
Yes, that's right. If the child is not able to be conditioned again or remain attentive, then you should probably use the OAE method or refer the child to an audiologist. And I just want to emphasize an important point here, and we've been doing that throughout today's webinar. But again, sometimes children with hearing loss are the very ones who are the most difficult to screen. So the last thing we want to do is to abandon the screening process on those children and just simply conclude that they cannot be screened without doing something else, whether that is screening with the OAE or making a referral to the audiologist.
You can guess, can't you all, why we keep saying that over and over again? Because that actually happens a fair bit, where the very children that need the screening result and an ultimate referral are the ones that don't get a completed screening. And so we want to make sure that doesn't happen. So let's say we do successfully complete the screening and we have one or both ears not passing at the second screening. We want to make sure we indicate that on the form, and then the child is referred for a middle ear consultation from a healthcare provider.
Now, for any child who is referred for a middle ear consultation from a healthcare provider, you'll want to use this diagnostic follow-up form on which you'll document the remaining steps in this child's screening and diagnostic process, starting with the results of the middle ear consultation. So since the child was referred to the healthcare provider to see if there may be a middle ear health-related problem that may have prevented the child from passing the screening on either ear during your first 2 screening sessions, you'll want to find out the results of this consultation and record them here. Then once the healthcare provider indicates that the ears are healthy and clear, then you'll want to rescreen the child's ear or ears that have not yet passed and record those results. And all children referred for a middle ear evaluation must receive the rescreen on any ear that did not previously pass. So if at this point there is still an ear that is not passed, then the child is referred for a complete audiological evaluation. And you're going to want to support the family in completing this very important step, and be sure to get the results, document them on this form. You'll also want to collect any additional supporting documentation of the audiological evaluation results, especially if a permanent hearing loss has been identified. So in most cases, this is going to include additional referrals for intervention services that you're going to want to be aware of so you can support the family in obtaining them.
So we do encourage you, even though we know many of you have moved on to electronic documentation, to look at these forms, because they do help you walk through the step-by-step recommended protocol that we want to make sure it gets followed. So have a look at those. So let's pause here for a moment and see if those of you who are using Pure Tone method have any other questions about this method, preparing to screen, conditioning, conducting the actual screening, or documenting any of the results. And after we take a look at any questions you might have, we're going to move on to the OAE method. So someone said, I work with children birth to 5 years of age. So can I use OAE for everybody? Terry, you want to clarify that?
Yeah, thank you for that question. Absolutely, you can. So some of the advantages of that will be that, in that especially 3 to 5 section of the children you're serving, there will still be, that 25% we said that wouldn't be able to complete the screening using Pure Tone, for example. So your OAE would be able to apply to them as well. But yes, you can.
Somebody is asking about documenting with citations what we were talking about, the doubling of the frequency of hearing loss between birth and school age. If you go onto our website, you'll find lots of background information and those citations from various sources. So we encourage you to look at that. The next question is, what concern do you have about non-audiologists screening with OAEs if they're not doing otoscopy first?
Yeah, thank you. We're not concerned about that. There's actually training to be able to use otoscopy appropriately as well, and to be able to identify the features you would be looking at. And so With lay screeners, we are not using otoscopy and don't have concerns doing. We just do a check of the outer ear, as mentioned earlier, and look for any deformities or drainage or any visible blockage. I'm not aware of any screening programs, are you, William, that have actually integrated otoscopy unless it's used by other trained personnel? Are you?
Only if it's a healthcare provider, a nurse, or a healthcare provider. The next question, and then we're going to move on to OAE screening, and it may be the perfect segue, is about whether we have any recommendations for screening children with special needs using either Pure Tone or OAEs. And Terry, I'll let you respond, but the first thing I would say, how great it would be to have both options available. And of course, that would require children who are slightly older and developmentally capable of doing pure tone screening, but they may be very tactily resistant to having an OAE done, which requires a probe insertion in the ear. So both options can be really nice under those circumstances. Terry, any other thoughts about that?
No, completely agree. Wonderful to have both options.
So let's move on then I'm going to just skip past our website here and we'll look at this again momentarily. Oh, but I do want to draw attention to this. Pure Tone Screening Skills Checklist is available on our website, and this walks you through each of those steps that we just went through as we walked through the process. So this is always a good thing to have beside you, especially if you're just starting up again after you haven't done pure tone screening for a while. It's also a really nice checklist to use for new screeners if you're monitoring how well they have done after the training or for evaluation purposes. So take a look at this checklist and see how it may be helpful for you and your program. All right, now we're going to turn our attention to otoacoustic emissions, or OAE screening. As we've already said, this is the recommended evidence-based practice for children birth to 3 years of age, and increasingly being used for older children as well. Terry, talk us through this process.
Okay, so again, we're going to start in the same place as we did with Pure Tone. To conduct an OAE screening, we're going to first take a thorough look at the outer part of the ear, again, to make sure that there's no visible sign of infection or blockage. If the ear appears to be normal and healthy, then a small probe on which we've placed a disposable cover is then inserted into the child's ear canal. And then a button is pushed to start the automated screening process. The probe that sits independently in the ear delivers a low volume or quiet sound stimulus into the ear. And a cochlea, or the inner snail-shaped portion of the ear that you see here, a cochlea that is functioning normally will respond to this sound by sending the signal to the brain while also producing an acoustic emission. And this emission is analyzed by the screening unit, and in approximately 30 seconds or so, a result will appear, either as a pass or a refer. So every normal, healthy inner ear produces an emission that can be recorded in this way.
You know, as you prepare for another round of screening, we want to encourage you to refresh yourself about what those steps are. And just as we showed you with the Pure Tone screening, we have a screening skills checklist for OAE screening as well that we'd encourage you to download. And that checklist can be used just as it can with the Pure Tone screening to refresh yourself on those steps, to walk a new screener through the process, and to make sure that they're following all of those. So get acquainted with what we find on our website. here, the training tools and all of the other resources there related to pure tone screening. So have a good look, or to OA screening. So have a good look at that. You'll see there on the bottom left, OAE skills checklist and the pure tone screening skills checklist. Those are under follow-up resources. So go have a look at those and see if they might be helpful for you. And this is what that looks like. Now, in addition to a list of the actual steps, you'll see a list of supplies that you need. So be sure to go over those to make sure that you're all set to go. Be sure to test your equipment on yourself or others. Importantly, on ears that typically pass, so that you're sure the equipment is working properly. In fact, we recommend testing the equipment on yourself prior to every testing session. If you haven't had the equipment calibrated in the last year or so, you'll want to do that to make sure it's working properly. Regardless of what hearing screening method you use, you want to make sure that you communicate with your parents and other program staff whose cooperation you're seeking, are clear about what you're doing and why.
Now, some of you have asked how to prepare children for hearing screening. And our main recommendation is to keep it fun, regardless of the method that you're using. So rather than referring to the activity as a screening or a hearing test, call it a listening game. And you can engage teachers and parents in some activities that include noticing the child's body parts, including their ears, and maybe expand on the idea of what animals have ears as well.
Yeah, and if you don't know, we have a short little video on our website called Listen Up that you can use with children if you have access to a computer. And if this is helpful in just setting the tone, you might want to play it or have even the parents play it for their kids at home. This is a quick little preview of that.
The donkey's ears stand up, up, up. The elephant's ears flap, 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 while the bunny's ears drip, 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 and the little kid's ears listen up. We have ears so we can hear. Check us out from ear to ear.
I'll hold you in suspense for what the rest of the little video is about, but take a look at it, and you'll find that here under a variety of other resources we have for preparing to screen. So take a look there. It's right there under preparing to screen, and that's where you'll also find our protocol guides and forms. Just like you saw with the Pure Tone form, we also have forms for documenting the outcomes of OAE screening that follows the protocol directly. So be sure to take a look at those, as well as the other preparing to screen resources that we're referring to right here. We really did try to come up with as many things that people would need on a daily basis in running a preschool hearing screening program. So certainly before you go sit down and write a letter or develop a form, look at our website and see if it doesn't already exist. Now, like many skillful tasks, competent screeners can make OAE screening look really easy. But no matter how much experience you have, we promise you're going to be met with challenges. We are always challenged, and a number of you have submitted questions about children you struggle to screen for various reasons. So let's take a minute and talk about some of those strategies for screening. We're going to start by looking at these pictures. Now, the children you see in these photos are all being screened using the OAE method. What do you notice about where they're being screened? They are being pulled out into an environment that's foreign or strange to them. They're being screened in everyday educational or home environments where the children are, for the most part, already happily spending their time. They're hanging out, they're sitting at a snack table or playing with some toys in a corner, or even in their outdoor play environment. And those people who are doing the screenings are people they already know. They're teachers, home visitors, or health specialists. And so there's a lot of familiarity already wrapped into this screening moment. So in fact, the screening works the best when children are familiar and comfortable with the adult who is doing the screening, and where they can play with a toy or be held or even sleep while the screening is conducted. And we're going to talk about sleep as an option in a moment. So we have lots of options. Now, some equipment is more effective than others when attempting to screen in natural environments. We know this, but most of these pieces of equipment that you can get will work fine under these various conditions. You may have to quiet the environment some, but they should be able to be done in these moderately noisy environments. Now, there are several keys to successful screening. Terry, you want to go over these keys?
Yeah, so there's 4 main keys to successful screening that we want to talk about. And the first is to ensure that you have a good probe fit. Second, we want to minimize movement. And then we want to minimize internal noise generated from the child. And then lastly, we want to minimize external noise in the nearby environment. Now, the goal with probe fit, the goal with a proper probe placement is that you have a really snug fit. We want to seal out all of the noise from that background environment. So this means you need to select as large as possible probe cover so that when you insert the probe into the child's ear, you can totally let go of it and it will stay in place. So you want the largest probe cover that'll fit in that canal. In fact, you have to let go, because if you hold on to it, your touch can actually loosen it, allowing more noise to get in and disrupt the screening process. The whole system is designed to be self-seated so you don't hold those probes in place. So as long as you select probe covers, always aim for the biggest one that'll fit in that child's ear canal. It's no great secret aside from experience in being able to make a good probe cover selection.
And you'll see in that photo there that the hand is not holding that probe in that little boy's ear, but you do see that clip there that is reducing the tension of that cord from pulling the probe out of the ear. So that's another really helpful way of keeping that probe seated properly in the ear. Now, some brands of equipment have a compressible foam cover, which tends to be the easiest to achieve success. So if your brand of equipment has a foam cover option, you want to try those, especially if you're having trouble with getting a good snug fit.
Let me interject just a moment, William. Just a little aside about probe covers. You can only use the probe covers that are intended or made for your device. So even though you may see others on the market, you can only use those made for your specific brand of equipment. Otherwise, you can get or will get inaccurate results. They are designed and calibrated for their own probe covers.
Now, Terry, some reassurance is needed here. Some people have raised a concern about their worries that they could hurt a child by inserting the probe, or that when they're helping to support a new staff member who's going through the process of learning, that new staff member is expressing that concern.
Yeah, we really understand that concern. And it's also the thing with more experience, you'll promise you'll feel more comfortable about it after you've screened lots of kids. But just be assured that these probe lengths have been carefully designed so that we can't insert them too far. Now, a child with an active ear infection, they may experience pain with the probe insertion. And that's one of the reasons why we want to carefully inspect the ear prior to doing screening. But otherwise, probes will not go in deeply enough to harm the child's ear.
So, and the videos that you see in the training and other resources we have on our website demonstrate how to do probe insertion, as you see in the photo here, and how we pull the outer ear back and then insert the probe in the direction of the child's nose, and then a little bit back with a slight twist to get it a snug. And then we always do what? We always let go.
That's right. You always let it go and it should stay put. And you also want to make sure that the cord has been clipped up, as you see in this picture, up here to the child's clothing. One, to get it, I always put it in the back to kind of get it out of their sight. But really, it's to keep the weight of the cord off the probe so that the weight of the cord doesn't pull the probe out of the ear. And these are two essential things for getting and keeping a good probe fit.
Now, of course, as you screen, there'll be times when you get an error message, and we referred to this earlier, and we can't go through all of the different error messages that across equipment, but we can give you some general guidance about what to do about error messages, because regardless of what the error message is, you're probably going to do the same thing and then try again. You're going to reposition the probe. You're going to reduce external noise. You're going to check the probe for wax and clean it off, or even replace it with a new cover if you need to. And you're going to make sure the environment is as quiet as possible, and you're going to try to settle the movement down of the child. So it's kind of good to know that even though there are different error messages that come up, the response to them is almost always going to be the same. And then last, you're going to use unique toys. You're going to try to distract the child, and you're going to just try again. If you can't still have success, you can always elicit the help from another screener. And then, if you really can't screen the child, as Terry has said over and over again, then you make a referral to an audiologist.
So, William, we've received a number of questions asking for suggestions on how to screen children who are just challenging to keep still, or for whom you just can't seem to complete a screening. So we'll go over some strategies, and then if you have any additional questions, we can take them. So there are several strategies that will help make the screening a positive experience for the children and for you. And again, I think I mentioned it earlier, we really want to create a fun feeling around the screening activity. So we want to position the child and yourself and other helpers in a way that's comfortable and allows the child's behavior to be naturally directed. We want to use toys and distractors and rewards effectively. And then we want to document the screening results accurately. So let's take a look at each of these for a moment. So first, talking about creating that fun feeling, we want to be sure to do that. So creating a fun feeling around the screening involves establishing rapport with the children. So for example, you may tell a child you're going to play a listening game and include another adult as the first person to be screened, placing the probe near their ear and asking them, for example, can you hear the little birdie sing? If you're working with a group of children, ask the teacher for suggestions about which child might be the most cooperative and should be screened first, so that we can set that good example and that tone for the other children to follow, so they see a positive experience right up front. I do want to just say here, and I think William will agree with me, that in our experience, this is what I think you are all so great at. We can teach technical skill and which buttons to push, but that natural ability to work well with children is something that we've admired when we've worked with many of you.
Now, when eliciting children's cooperation, you still want to tell them what you are doing rather than asking them if they want to participate, right?
Oh, yeah, that's actually very important. We don't want to give them the opportunity to say no. So we say, we don't want to say, can we screen your ears or can we test your ear? We don't want to give them that opportunity. So you direct the screening.
You may even suggest to the other children that they may have to wait their turn, just like they would with other fun activities. Assume it's going to be perceived as fun. This can create the desire for them to participate and be next. And be sure to use terms that describe the activity as fun and interesting, and avoid using phrases like testing your ears or trying to be reassuring by saying it won't hurt or won't be painful, because they're going to hear the word hurt and painful, and you're not going to like the response that you get.
Yeah, exactly. Thank you, William. Now, in terms of positioning, you want to position yourself to the child, to the side of or slightly behind the child, because that'll give you good access to the ears to facilitate probe insertion. If it's possible, have another adult hold the child snugly or keep the child distracted or their hands occupied with another activity. And it's great to sit on the floor at their level. I do that often.
Yeah, and you know what I want to insert here really quick, Terry, is these strategies are the ones you need the most when we're talking about those littler children. If you're the ones that are thinking about using OAEs with 3 to 5-year-olds, it'll be a breeze. It's really not hard to get them to cooperate with this. You just give them something to look at or a toy to hold, and it's not difficult. It's these littler children that are more difficult.
Yeah, they are. So having some good toys as distractors is always helpful. You want to present new or novel toys and distractors at the moment that you most need the child's cooperation. So if a child loses interest in one toy or a distractor, present another one and have those ready.
Sometimes a gentle caress or playful touching game can distract the child from the sensation of the probe in the ear.
And introducing something that captures their attention through another sense can help distract them from the sensation in their ear.
Now, once complete, reward the child with praise, and if desired, maybe a sticker or reward, making sure that the same praise and the same reward is given no matter what the screening outcome is.
It's also really helpful to screen in teams, so you can have one adult manage the child while the other one is focused on completing the screening. Now, we'd like to show you a variety of strategies for engaging children in playful ways that will help you be successful, as well as adding a few cautions about some common errors to avoid. So a very important strategy is to keep those little hands away from the probe. So we want to redirect the child to manipulate an object or to grasp an adult's finger or hand, but keep them busy. And offer the child choices about where to sit or what toy to play with, but not a choice about whether to be screened or not.
You can also familiarize the child with the probe before attempting to insert it into the child's ear. And you can do that by touching their leg or their arm or their hand or their cheek with it, pointing out how soft it is. You may even also have the child's help in pretending to screen a doll or a stuffed animal. Sometimes a young child will cry when the probe is inserted. And you don't want to necessarily automatically remove the probe, even though that may be your first impulse. Instead, let the child relax with the probe still in the ear. Have your finger close to the start button and be ready to push start the moment the child is quiet. Sometimes you can complete the screening from that moment, even if the child continues to be a little fussy.
Now, if a child's uneasy about being screened, but they can be soothed by using a pacifier or giving them a snack, you can go ahead and attempt to screen while the child is sucking or chewing. It does introduce noise as they're sucking or chewing. So if the result is a refer, you'll need to repeat the screening when the child is not sucking or chewing. But you can sometimes still be able to complete a screening as they are sucking or chewing. Now, another strategy to consider is screening in groups. And this can help some children who might be fearful to become fearful about the screening to become more comfortable with the process, as long as they're seeing that others are having a positive experience. So like we mentioned a little earlier, you always want to try to start with a child that you or the teacher is fairly confident will be cooperative and set that positive example you're hoping for.
Now, we mentioned sleeping. Sometimes children who have been treated repeatedly for ear infections or other conditions can be especially reluctant or resistant. And you may need more time to watch other children participate in the process to just get a little bit more comfortable with the whole idea of it. But another option, and this can be used with any child, whether they're reluctant about it or not, is to screen children while they're sleeping. And so you can always do that, especially with the little ones.
Yeah, actually, you don't even need a reason to screen children while they're asleep. It can be a great strategy that way. So I've often used that. Now, remember, if you do not get a passing result, as long as the child's cooperative, go ahead and try the ear again, making sure, like we mentioned, that you have good probe fit and that you've minimized internal and external noise. And again, it's very important that once that screening is complete, that you be sure to document the results accurately.
Yeah, and in terms of documentation, this is our screening form, which follows the protocol step by step exactly. So if you haven't been using this or haven't been acquainted with it, we encourage you to take a look at how it walks through the complete process. I want to make sure we have time to go over the protocol. So let's do that. And as soon as we wrap this up, we'll open up for questions about OAE screening or anything we didn't address about pure tone screening. Now, the screening and follow-up protocol for OAE screening and pure tone screening is exactly the same. And just keep in mind that our best efforts at screening are only worthwhile if we implement effective follow-up. So let's take a walkthrough of the follow-up protocol and see if you have any questions about that. So one of the good things to remember is that the steps of the follow-up protocol are the same, as I said, regardless of what screening method or how old the child is. And there's one main rule to remember. The screening and follow-up process is complete when either the child passes the screening on both ears or the child has been referred to an audiologist and you've obtained those results. The screening and follow-up protocol and the accompanying forms we've got on kidshearing.org walk through this process step by step. So if an ear passes the first screening, the process is complete for that ear. If the ear doesn't pass after several attempts during the initial screening session, we can't be sure why. Sometimes it's due to screener error or a temporary condition like a head cold. So it wouldn't be practical for every child who doesn't pass at that first screening to be referred to a healthcare provider or an audiologist. So several participants have asked Terry, What about a head cold? Congestion can affect screening outcomes. This is where we might see that, right? Can you go over that, Terry?
Yeah, absolutely. You know, maybe, for example, in the fall, it's cold and flu season, and so we may temporarily have that congestion or middle ear fluid, but the protocol will walk us through that and get the appropriate follow-up. And so my recommendation is follow the protocol.
Yeah, and so in 2 weeks we screen again, and if the ear passes, the screening is complete for that ear. If, however, the ear still doesn't pass the screening, then further evaluation is needed. And we expect about 8% of the children won't pass the second screening. And in fact, will need to have their ears checked by a healthcare provider using what's called tympanometry or pneumatic otoscopy. It's not uncommon for them to find wax blockage or fluid or inflammation in the middle ear has prevented the screening of the inner ear from having been completed. So what then, Terry? They're at the healthcare provider.
Yeah, so at this point, that's actually when you want to intensify your monitoring of the child's follow-up. So consult closely with the healthcare provider to find out first the results of the middle ear evaluation, and second, any treatment that's being provided. And again, always document the results of that middle ear evaluation. Now, this important point, keep in mind, since the ear hasn't yet passed the screening, we still don't know if the inner ear or the cochlea is functioning properly. And unfortunately, most healthcare providers do not have hearing screening equipment and therefore cannot complete the screening process. So you'll need to confer with the healthcare provider about when that ear should be rescreened. And then after the middle ear evaluation, go ahead and conduct a rescreen. And then if the ear passes, the screening is complete. If the ear still does not pass, that's when the child should be referred to a pediatric audiologist for evaluation.
Less than 1% of the children you'll be screening will typically go this far in the process, but it'll be helpful to inform healthcare providers who are involved in the middle ear evaluation step that they may need to make that referral to the audiologist should the ear not pass the rescreen. You'll want to be sure then to support parents in audiological evaluation completed, to provide the audiologist with all of the screening and follow-up health-related outcomes, and then to obtain a complete report from the audiologist's evaluation. So that gives you an overview of the complete screening and follow-up protocol. And just, remember, all of this is on our website that you can review anytime. And keep in mind, too, that if children pass, but parents remain concerned about their hearing or the child's language development, always make a referral for an audiological evaluation. That's always warranted, and it overrides a passing screening results. All right, so we know we have a number of questions that you are asking. So let's look at some of the questions that are coming in. Can someone who has been trained to use the OAE train a new staff? Does it need to be represented from an OAE company? So our advice about this is that you want to make sure that everybody gets trained exactly the same way, that you don't end up passing on information like that telephone game where it changes a little bit from one person to the next and then to the next and then to the next. And so that's one of the reasons why we have a standardized curriculum available on our website to make sure that that is done. So we'd encourage you to check out that, or if you have a local audiologist or somebody in your state that offers that kind of training, to access that as a part of this. As far as getting the training from the equipment supplier, we kind of caution you about relying on that as your training, because they're not really prepared to help you develop a screening program or to develop screening skills. It's kind of akin to the way you might look at a car salesperson. A car salesperson will show you all the functions of the car, how to roll the windows up and down and all of that stuff, the fancy features of the car, but they're not going to teach you to drive or how to parallel park. So by all means, have a listen to what the manufacturer or salesperson or distributor can tell you. They may get way over your head and show you parts you don't even need to know about the equipment, but you're going to need more training than what they typically can provide. Terry, this next question is, does holding the OAE ear tip in the ear really impact the results of the screening? I find most of the tips, even when we try various sizes, just don't stay in the child's ear due to most children not being able to sit still.
Great. So two thoughts here. My first is that yes, it does impact the results of the screening. Often as the child moves, that finger can then press as they move, it can press that finger up against, or the probe up against ear canal and actually block it. And then we would get a refer. And so they are designed to be self-seating. And I do hear you with probe covers not staying in the probes not staying in the child's ear as they move. It is one reason that, as William mentioned earlier, we found those foam probe covers that we squish down, place in the ear, and they expand to be self-seating much better than more of the plastic tips. So if you have a foam tip option, I'd encourage you to use that if you can.
The next question illustrates one of the reasons why it can be really helpful to have an audiologist nearby to consult with. But Terry, here's the question. On our OAE equipment, there are settings that indicate protocol DP where it says you can pick between 2S to 4S. Do you know what that means?
Yeah, so we're getting into settings here that are really specific. What we really want to do is to use the basic screening protocol on your equipment. And so this is a great question for your program audiologist or your equipment manufacturer, but you want to use the basic screening option that is on there. There are all kinds of settings that change, that you can change from adding different frequencies to length of time that it screens. And so, yes, that does refer to the amount of time that probe is looking for the response. But again, I would confer with your program audiologist and or the equipment manufacturer.
On our website, which you see right here under planning resources, do you see the third one that says screening equipment? We'd encourage you to go look there because we do offer some basic specifications on what you would want to have your basic equipment set at. So that you might want to refer to in addressing questions like this and others related to settings of your equipment to make sure that you're screening at the appropriate frequency levels, etc.
William, there's a really great question that says, when screening a group of children, how do you clean the probe before placing it into another child's ear to be screened? And that's what the probe covers themselves are for. So again, you always want to look at your equipment, check it out before you screen and in between each child. So look at that probe, make sure that it's not blocked in any way. You can clean that probe with a soft, moist cloth, always wiping away from the probe, the base of the probe itself. But the part that makes contact with the child's ear is the probe cover, and those are one-use, disposable only. You can use the same probe cover for both ears of the same child, but never the same probe cover for multiple children.
The next question is, can you give specific direction on where to find the forms on the website? So yes, on the website right here, kidshearing.org, if you go under where it says screening resources, it's about in the middle of your screen there, right? The second area that says protocol guides and forms. The next question. Every once in a while, I can't get the OAE to move from probe check screen to the actual screening screen. It is like the OAE doesn't know it is in an ear. What can I do to resolve this, or can it be resolved? Is it a fail, or do I try again in 2 weeks?
Great question. I'm going to start at the bottom, or your last question. Is it a fail? It's not a fail, because we've actually never even moved to screen or collect any data from the child. Now, having said that, it's a common probe error message that you may get when the machine says, you don't have a good enough fit, and there's too much noise getting in, and it's not able to progress from checking the probe fit to the actual screening. So it is a common error, and usually you want to refit and retry. However, what I am suspecting you are probably meaning is that the machine seems to get stuck there. And what I would do then is to completely shut it down, turn it off, and then restart it. And because sometimes occasionally machines will get stuck there, and hopefully that will help. If you're not able to, then go ahead and check your equipment operation by doing a check on yourself. And if you can't get it to work, then it probably needs to be seen by your equipment manufacturer. But
well, we can really sympathize with those of you who are trying to use a piece of equipment, and sometimes it does stuff that you just flat out don't understand. And that really is, I mean, you can always email us if we can be of help, but it really underscores why it is so nice to have a local pediatric audiologist who can volunteer if possible to help you out occasionally with some of these moments where they could come and look at the equipment or help you with a given child. So we really encourage, if there's any way to find that person, it's worth building the rapport with them to have them as a consultant to your program. And a lot of people will work with programs on a volunteer basis, given all that you're trying to do for children. We have one more question, and then in a moment, you're going to see in the chat field a survey that you can click on to give us a quick feedback on today's webinar. And once you do that, it'll generate a certificate of attendance for your participation in today's webinar in case you need to document that you've been with us today. So that will appear in the chat box here in just a moment. So one last question. Can a screening program, this is kind of a review because we have talked about this, can a screening program move forward with only OAE for children under 5? Or is Pure Tone always the gold standard for 3 to 5s? Terry?
Yeah, great question. So it's historically been the gold standard for 3 to 5, but now that we have the option, the gold standard really is to be prepared to screen every child. And so as we mentioned, ideally, if you have both as options, wonderful. But in order to screen every child, then you can move forward with only OAE for children under 5. And then, of course, taking into account your, any health advisory programs, consultation with audiologists and your team, whatever it takes to get those approvals in your policies and things like that.
If you direct your attention again to the screenshot on your screen of our website, kidshearing.org, under that first item that says Big Picture Resources, under there you'll find a document that compares OAE and Pure Tone screening considerations for 3 to 5-year-olds. If that's your question, you'll want to look at that document and then make a decision with your health services advisory team or whomever else is designated for your program. We are at the bottom of our hour and a half. Thank you, everybody, for your time and attention today, for these excellent questions. More importantly, for all that you're doing amidst everything you have on your list to focus in on monitoring the hearing status of children that you serve. We put a great deal of emphasis on the importance of language acquisition in young children, and hearing receptive language is a critical part of that. And you seem to understand the importance of that. This isn't just a requirement that needs to get checked off doing hearing screenings. It is an important part of making sure that all children have optimal access to language as they're learning language. And even a mild hearing loss or a unilateral hearing loss that goes unaddressed can disrupt that language learning process and their overall development and as educational readiness. So thank you for that. And remember to pass that idea along to your colleagues and to the parents of the children that you serve. Another shout out of thank yous to our captioner and to our interpreters today and to our background support folks. Thanks, everybody. And Terry, of course, as always, thank you. Tomorrow is another webinar. So if you or of folks that are really needing to learn about evidence-based hearing screening practice for the first time, that's what we're covering tomorrow. It's going to be more basic than what we talked about today, but it will cover both OAE and Pure Tone screening to help people know about the basics of developing OAE and or Pure Tone screening. So send people our way, and if they need to register, they can go to kidshearing.org. All right, the link is posted in the webinar chat field to do the quick survey and to get your certificate of attendance for today. Thanks, everybody. And no, today's webinar has been recorded and will be posted on kidshearing.org and infanthearing.org in the next couple of days. Thanks, everybody. And Gunnar, if we can just if you can keep the room open for a few minutes so people have a chance to click on that, that'd be great. Thank you.